Thank you. So I'm Ngozi Elumogo. I'm a clinical microbiologist, and I've worked in the NHS for many, many years, and at consultant level, 20 years. So infectious diseases basically is my specialty. And like Simon said, this is very much a collaboration between the clinicians and the researchers. And that's the beautiful thing about the Quadram, that is bringing together people who work in the hospital and people who work in science to make sure that we're able to translate the science into patient care. Okay, so my brief this afternoon is to just explain the safety of the fecal microbiota transplantation that we plan to use for this study. So why do we do FMT for short here? It's because we are really lucky in having, within this space, this research park, the most, I would say, endowed part of collaboration between the clinicians, so next door, big hospital, science right here, food, gut, all the expertise within a very close proximity gives us this huge advantage to be able to bring this therapy in. And you might be surprised to hear that there are very few centers in the UK that can actually do fecal microbiota transplantation. I know there are, reports in the media of people doing this in their own home out of desperation, but that is really not to be recommended because there are some risks which I am going to highlight, and I will explain to you how we mitigate those risks. So I'm not going to dwell on this because Simon's dealt with it, but I'll just mention the last part, which is it's not just humans who have used other people's feces, but actually, if you look in the animal kingdom as well, you will find that there are certain baby animals that eat their mother's feces to be able to get bacteria into their own gut so that they can metabolize and digest food. So it's quite a practice that is widespread in nature, and that is called Coprophagia. And if you are an animal lover and you've got pets, you're probably familiar with this. It's quite interesting when I saw this to say that there is actually a product that people who have dogs can buy to stop their dogs running off to eat poop when they take them out walking. I thought that was quite interesting. We have experience in doing fecal microbiota transplantation in this place. And this started on the back of the NICE guidance that was published in 2014, which gave us the approval to bring in fecal microbiota transplantation specifically for patients who have very bad Clostridium difficile infection. Can I just check, are people familiar with C. diff? How many people have heard about C. diff? Hands up. Yeah, thank you. So essentially, it's a disease that's mainly brought about as a side effect of antibiotics. So antibiotics decimate the gut microorganisms, like the slide that Simon showed you about the lung being completely denuded. That's what antibiotics can do. And before FMT, we would use more antibiotics to try and treat the C. diff, which doesn't make a lot of sense, but we didn't have anything else. But as soon as FMT became approved, we thought, yes, we now have a tool that can actually bring cure and give that gut microbiota the opportunity to reestablish itself and become colonized with healthy bacteria. So NICE gave that recommendation because they looked at the evidence, and particularly the first randomized control trial that was published by the Amsterdam Group in 2013 that showed that FMT was both efficacious and safe. So that efficacy is in relation to Clostridium difficile, but I'm here to just emphasize the safety component of it. So that is to say that NICE has actually looked at FMT and they deemed it safe within certain parameters. And if you read further, you will see that it's saying that clinicians have to be involved and make sure that there is clinical and safety governance around the whole process. So that is what I bring to the trial as a clinician to say, how do we make sure that the donors are well selected, that the stool samples are screened properly, and that we have traceability to be able to go back if we needed to check something. Do you agree that that's quite a good thing? To be able to go back if there was an issue to say, okay, where might this have arisen? And I'll just pause a bit and maybe remind people, because this was quite high profile recently, where there was the court cases just talking about the unfortunate blood-borne virus scandals, quote and unquote, where people were inadvertently infected with HIV and hepatitis C. So I see people nodding. So that is not that long ago. It's still very fresh in our memories. And so we are very cautious as clinicians that when we bring in new therapy, we absolutely must make sure that the safety aspect is considered. Because again, as doctors, when you graduate, the first oath you take is first, you do no harm. So whilst you want to improve patients' quality of health and improve, bring cure where possible, the starting position always is the safety aspect, that you do not complicate people's lives by causing harm. Okay, so I'm just going to skip those through. So the stages in our FMT, as you can see, there are quite a number of things that we do. But the first thing really is that the donors that we use for the feces that we use for the transplantation comes from healthy, at the minute, scientists that work within this park. So I have made a decision not to use clinicians, because as clinicians or people who work in the hospital, we are in contact with patients all the time. So that means that we could inadvertently pick up something, and it's more difficult for me then to have the peace of mind that what I'm preparing is going to be, free of pathogens. So we've chosen to use scientists who are motivated, who understand the importance of donating, and who are committed, and who are coming to the place anyway, so it's a bit easier, but who are also incredibly supportive of the research that we're trying to do. So that's where we get our donors from. And I'm just going to show you a slide about the initial questionnaire that we do. So we put out a call to say, we want people to join our donor register within the park, and people contact me, confidentially to say, yes, I'm interested. And the very first thing I ask them is this whole questionnaire. Some of the questions are a bit intrusive, but we need to know if somebody's got a risky lifestyle, for instance, if somebody unfortunately uses drugs, we know that that could be a risk for blood-borne viruses. And then there are a whole list of gastrointestinal comorbidities, which we want to exclude just from the history. So before we even start to say, we want to screen the donor, we have to go through these, every single one of them, and make sure none of those apply. So some of those are absolute, and so some of them are relative exclusions. So a relative exclusion, for instance, could be that somebody's is just come back from the developing world, for instance, where they might have traveler's diarrhea, because we know that's more common, and then we need to wait at least 6 months before they can join. Or somebody's just had antibiotics, and 3 months, we need to wait at least 3 months to make sure that their gut flora has been reestablished. So we do the questionnaire, first of all, and ask lots of history. And if none of these applies, and it's absolutely clear, we then invite them. We'll go through a very detailed consent process, and I do this personally because I need those donors to think about the possibility of a result which they didn't think that they might be harboring. And I think that's really important. So whilst people want to support the study that we do, they've got to be really informed and think about how that might change their lives if they were suddenly found to be hepatitis C positive, which they didn't even know that they had. So I go through that, and I give them the forms, and they say, go away, think about it. And if you're really up for it, then you can come back. And then when they come back and they're ready and we sign the consent forms, we then ask, I do the blood forms, and they go to our phlebotomy to collect blood for general checks, so things like electrolytes and urea, liver function tests, your CRP, which is a marker of inflammation, and then more specific tests, screening for all these pathogens here. Now, there are now UK and European guidelines about FMT, which has been published in the last couple of years, we at this site actually do more than what's in the national guidelines, which we contributed to. So some of the things that are extra are that we screen for drug-resistant organisms. Now, extended spectrum beta-lactamases, many of you, I don't expect you to know about them, are drug-resistant bacteria that can live in the gut. They don't cause symptoms, but they just sit there. And as a clinical microbiologist, I do not want to infuse feces that's got any resistance that I can identify. So we screen for those. We screen for vancomycin-resistant enterococci, which also lives in the GI tract. We screen for MRSA, which I think many of you will be familiar with because it's been so much in the news. And some people can carry MRSA in their gut as well. And then we screen for carbapenemase-producing Enterobacteriaceae, in addition to the food poisoning organisms that you all will be familiar with, Salmonella, Shigella, Campylobacter. We use molecular methods now to test for these, which means that it's really sensitive, so we do a PCR. So it doesn't have to be that they are viable or alive. I just want to know if they're there at all, then we can pick them up. So I am really reassured that our screening methods are very robust and will pick up even small fragments. So that's the kind of panel of tests that we run in the lab before we even accept any donation. And I'm going to, so very briefly, the method that we do here is to use the nasojejunal tube. So that's a tube that we put endoscopy downstairs. We put a tube down through the stomach and into the small intestine. And the idea being that we want to infuse the material into the small intestine, and then it can go through to the large intestine, and you have a longer route for it to work. There are other methods of administering fecal microbiota transplantation. There are places that might choose to put it in the stomach, and they will do a smaller volume, or to use the bottom end and do a sigmoidoscopy. And there are a few cases that we've had to do those if we felt the patient was not suitable for upper GI tube insertion. So that's just the final product, the way that we package it, and we just put it in these really beautiful syringes. And it's come after your lunch, but hopefully you don't get squeezy or anything. And we then go across to the patient's bedside and infuse that into the tube, which is put through the nose, like I explained earlier. So that's the delivery route that we use most of the time. But occasionally, we can use other routes as well, particularly in treating Clostridium difficile, if we perceive there is a risk of putting a tube through the upper entry route. So by way of side effects now, if you look through the literature and in our experience as well, there are some minor side effects that people get when you give them, any material that you put into somebody's tummy anyway. So things like belching, some abdominal cramps, some tummy pain. And there are risks that come from the route of administration, and that's also something that will come out of the clinical assessment before the route of FMT is chosen. So if somebody, for instance, has issues maintaining their upper airway, then you don't want to give them upper GI endoscopy. So there are risks associated with the tube insertion itself, which is done by the gastroenterologist downstairs. There is, of course, the possibility of an infection, which is why NICE has said this has to be done within a clinical setting, and which I have explained how far we go to screen a whole list of things. There are things which we don't know, which we can't screen for, but at least I think it's something that people have to understand, that at this moment in time, everything that we know we ought to be screening for, we are screening for. And to give that extra assurance, we've got a biorepository within the site as well, where we store aliquots of the feces that the donors give, and for C. diff patients, we also store their own feces, so that if there was a complication or a complaint further down the line, we can actually retest the donor, the specific sample that was donated, not the one that we tested before they became a donor, but the one they donated on the day which is stored indefinitely at the minute, we can go back to it in frozen aliquots in the biorepository, as well as the one from the patient themselves. So in our hands, it is very safe. And there are all sorts of future developments that can happen. But of course, intervening, using it as a tool to study ME is what we are discussing today. But it is a very new and exciting area of research. And I think the potential is definitely huge. And this is one of the ones I like to show to my C. diff patients when we talk about, because you got to consent the patient as well to give them FMT. And I say, well, feces is a natural product, you know. It's not a pharmaceutical agent in that sense, even though the MHRA has categorized it for purposes of clinical trials as an investigational medicinal product, which is why we're applying for the MHRA license to be able to do the trial. But if you actually think about it, it's not being given the same definition when it comes to using it for Clostridium difficile, because they've allowed us to use it without calling it a drug in that sense. But that's the way that they've chosen to do it. And that's the same way that Europe has gone, because we have Europe-wide collaboration, and that's what it is at the minute, categorized as a medication. But it is a natural product. And I say there is no supply problem. There usually isn't. So we can often get as much as we want, so long as we arrange it in advance, which is good. Well, I said there is no direct cost, because the colleagues and the scientists who've been supporting the treatment we've been given here, we haven't had to pay them anything, because that's just, the NHS doesn't pay donors. We don't pay blood donors, so why would you pay people who donate feces? I said there is no overdose, so unlike a medication where you might find you've taken too much, there isn't really an overdose for FMT, and there is no underdose either. But we have the standard dose that we use at the present time. And of course, because it's not a medication, there is no drug interaction. So I can't think of any other clinical trial that you sign up to that you wouldn't have a long list of check with medications. Are you on this, are you on that, and the other, and how the trial medication may interact with your current medication. Luckily, that's not actually an issue with this sort of therapy or trial. So, there's a whole list of advantages here and things that makes FMT lend itself clinically to this sort of trial, and we're really excited about that. And finally, I think it would just be to emphasize again that this is very much a team effort. I've got other clinical colleagues, so I'm the lead clinician for FMT, but I collaborate with some of the gastroenterologists. I've got older people medicine consultants, and we all work together just to make sure that the treatment is available and to C. diff patients who need it at the moment. And that will be the same thing when we come to use them for clinical trials.